orthopedic surgeries, providing holistic care to his patients. Beyond his clinical responsibilities, Dr. Revankar stays abreast of advancements in orthopedic medicine through continuous learning and professional development. His dedication to improving patient outcomes and his active involvement in teaching and mentoring younger medical professionals reflect his commitment to excellence in the field. With his expertise and compassionate approach, Dr. Suraj M. Revankar continues to make a positive impact on the lives of his patients and the medical community in Mangaluru. On behalf of Srinivas Institute of Technology and the organizing team of FDP, I extend a warm and sincere welcome to you, sir. Now, I
Hello.
would like to invite Dr. Suraj Revankar to take over the session and share his valuable insights with us. Over to you, Dr. Suraj Revankar.
Hello. Good afternoon to all of you. I hope
Good
I'm
afternoon.
audible, right?
Yes, sir.
Yes.
Yeah. So we'll be discussing today about the biomaterials that are being used in the orthopedics. Yeah. So first, the materials that are commonly used in orthopedic practice, we're going to learn about that. And then on the basic science of the biomaterials that are commonly used in the orthopedic practice. And then we'll read a bit about the recent advances that has happened regarding the implants that we have been using. Okay, first, what are biomaterials? They are synthetic or treated natural materials that are used to replace or augment tissue or any organ function. If you have any fracture or any bone that is fractured, we'll have to treat them immediately so that the patient can walk again, or any upper limb fractures, we'll have to treat it immediately. So orthopedic biomaterials encompasses all the materials used during the orthopedic procedures. Most of them are man-made. Okay, that's, as I said, it's any material that performs, aids, or replaces a natural function. In this picture, you can see some of the implants. The first one in the corner, the top left, it's a knee joint where you have a knee joint is made up of two, thigh and the leg. The thigh is the femur and the tibia. So you can see the knee component and the tibial component, both of which are stainless steels. The next one is the hemiarthroplasty, where a patient with a fracture of the femur has been treated. The third image down, it's a tibial nail that is used to treat the fractures of the tibia. And the fourth one, it's how you temporarily immobilize the limb, or keep the limb so that you cannot the patient is immobilized temporarily so that the wound heals, and then we can operate on him. This is just the basic. Okay, so if you go to the history, Aztecs are known to have been using gold and silver. In the 16th century, they used to use wooden sticks to immobilize the limb so that the pain can be reduced. In the mid 1800s, the ivory pegs were inserted into the medullary canal. The medullary canal is nothing but the inside part of a bone. So ivory pegs are introduced into the medullary canal if they fail to unite. As it progressed, autogenous bone grafts started getting used as an intramedullary implant. Intramedullary means inside the bone. So this structural augmentation of the bones began in the 19th century. This, you can see in this, there's a plate kept. That was one of the earliest plates that was used in the 1900s to treat a fracture. So when we go into see biomaterials, what are the main qualities that we look in a biomaterial? First thing, it should be biocompatible. Biocompatible means that the body should not react to it as an outside object. Anything, if there are metals, it will undergo corrosion with time. So it should be resistant to corrosion and degradation for as long as possible, and should have the highest standards of quality control. And it should be inert. Inert means, but it should not trigger a significant immune response. Anything in the body that does not belong to the body will usually trigger an immune response and try to kill it. So we have to find an implant that is not going to trigger any significant immune response. Reasonable cost, as it's understood that the cost has to be lesser for any patient to be able to afford it. And it should obviously have adequate mechanical and wear properties. As time goes on, there is wear and tear of every metal. So the one with the good wear and tear properties, which does not undergo wear and tear sooner, are preferred. So these biomaterials that meet this criteria have been used to develop for internal fixation of fractures. Osteotomies. Osteotomies nothing means opening up of a bone and fixing it. And arthrodesis. Arthrodesis is fusion of a joint. When the situations come where you cannot give the patient a full flowing joint, you fuse the joint so that he can walk. Arthrodesis, for that also implants have been used. Wound closure. Any wound, the patient comes with an open wound, the wound needs to be closed. For this also we use sutures. I'll discuss about that going on. Soft tissue reconstruction, total joint arthroplasty, nothing means a replacement of a joint. So replacement of any joint, as I showed the first picture which I showed, that is a replacement of a joint. Then prosthetics. So basically they're divided into two groups, natural and engineered. So beginning, in the very beginning, the first generation which the biomaterials had come, they were bio-inert. So any material that which did not get an immune response from the body, they started using it. But as the time went on, the second generation came where they started getting biodegradable materials. So what are biodegradable materials? So any implant that you put into the body, after its work is done, you have to remove it. But biodegradable materials get absorbed into the body. So this will, reduce the chance of reoperating and removing it. Next came third generation, which stimulates specific response at a much deeper molecular level, where the implant itself will stimulate better healing. Yeah, this just to know what an implant does. A load is a force that acts on the body. So compression is perpendicular to the surface of application. So any implant that has to be put in compression. Shear forces are the ones which are parallel to the surface, and torsion are the forces that cause rotation. So all these three forces have to be balanced with an implant. Stress is how much the implant is bearing the stress because of the body, that is forced by area. Now next, coming to the materials, they are classified into different types. The brittle materials are the ones that are not directly used to immobilize, but they are used with another implant. I'll come in detail about it. Next is the ductile materials, that are the metals. Viscoelastic materials, that are our body's own ligaments and bones. Isotropic and anisotropic materials. So these are the basic 5 materials that we use in orthopedics. The alloys, metallic alloys, polymers, ceramics, bones, ligaments and tendons. We'll learn about each one. So what are metals? Metals are the crystalline arrays in which the atoms are regularly spaced and packed in a specific configuration, allowing for share of the outer electrons. Metals are obviously commonly used in almost all orthopedic surgeries. So what are alloys? They are the composed of mixture of both metallic and non-metallic elements. So these alloys, they improve the strength, ductility, elastic modulus. If it's completely non-elastic, the chances of the metal breaking are high. So they should have some degree of elasticity, the resistant to corrosion and biocompatibility. What are polymers? Polymers are basically large molecules that are made of combination of smaller molecules. So the three basic, the ones which we use are PMMA, that is polymethyl methacrylate, also called as bone cement. Next is the ultra high molecular weight polyethylene. Then some are the ones which can be absorbed by the body. Coming to the PMMA, this is the bone cement that we use. It is one of the most commonly used polymers in orthopedics. Okay, the two bone cement can come in both powder material and a liquid material. Bone cements are used when, for example, if an implant is placed into the body, it cannot completely fit exactly as you want. I'll come in detail about it in the future slides. So the bone cement can be in a powder form or a liquid form. The powder form is the PMMA alone or with a copolymer of polyester. It can be seen in a liquid form also, that is the pure methacrylate only. This is a picture of a knee joint where they have put bone cement pieces coated with antibodies so as to prevent infection. So this how the bone cement can be placed into the joint. So what are the advantages of this bone cement? First of all, it reaches the ultimate strength in 24 hours. So as soon as you apply it, it does not reach the ultimate strength. Once you apply it into the body with an impression, with the implant, ultimate strength it reaches in 24 hours. It is strongest in compression. But what are the disadvantages? Obviously, something that is not a bone, it acts like a bone, but it's still weaker than the bone when tension is applied. So when you put a bone cement into the body, it develops an exothermic reaction that it elevates the temperature of the surrounding tissues. So sometimes if there's any important arteries, veins, or nerves around the cement, it can cause damage to them. Where debris and where related bone loss can also be seen. And every time we put a cement into the body, it can cause a dangerous drop in blood pressure. So oftenly the failure is caused by microfracture or fragmentation. So where are these used? Arthroplasty, as I said, it is a replacement of a joint. In this picture, you can see this is a hip joint. Okay, the hip joint, they have put another implant into the hip joint. Okay, so the stem part of the implant cannot perfectly fit into the bone. So as to make it fit properly, we first fill the femur bone with cement and then put so it does not act as an adhesive, but rather as a space filler. So any part so it acts as a compact implant into the body. It can also be used to stabilize osteoporotic fractures. Osteoporotic fractures are as the age develops, the bone gets weaker and weaker. So to stabilize them, osteoporotic fractures of the spine can also be stabilized using these things. And some tumor defects, when there's a tumor in the body or in the bone specifically, that tumor, once you remove, that part of bone won't be growing. So there is a bone loss there. So how do we fill that bone loss so that patient can, walk normally again? That bone loss can also be filled with cement. Cement just fills into the bone defects, which is caused by the tumor, and then it will prevent the local recurrence. So any tumor that is removed, there's always a possibility of it recurring, that the patient can get the tumor back. So once we fill it with cement, there's no chance for the recurrence, or the chances for recurrence are lesser. Next, coming to the ultra high molecular weight polyethylene. Okay, this has a higher impact strength, toughness, and better abrasive wear and tear. So that is better means the wear and tear is lesser. So this is the one. This what we are seeing. It's called a spacer. This is what is placed between the knee implant and the tibia implant that we use in the knee replacement surgeries. Between both the knee implant, that is the knee component, and the tibial implant, that is the tibial components. In between that, something we keep, that is a spacer. So this cannot be seen in an X-ray. This is made up of ultra high molecular weight polyethylene. It's tough, ductile, resistant to wear and tear, but more than the metals, these are more susceptible to wear and tear. So more susceptible to abrasions. The wear debris of these polyethylenes are more compared to the other things. Then this is the advancement that has come with time. This may not be present in the beginning 1900s, but now it's very well used. Those are the biodegradable ones. So any implant that we put into the body, after some time we'll have to remove it. But these biodegradable ones, they will slowly, chemically and physically over time get absorbed into the body. So you don't have to remove it. So as stiffness of the polymer increases, stiffness of the callus increases. So what is callus? Callus is the new bone formation that occurs in the body. So when you put a biodegradable implant, that gets absorbed into the body and it helps in increasing the bone stiffness. Strong enough at implantation and slowly it degrades, the biocompatibility degradation products are seen. But to get these properties are not easily provided, can span an enormously large range. Yeah, as I said, it's used for fixation and support of a suture. The suture materials that we use, suture is how do you close a wound. Usually when we close a wound, the suture materials that we use is the biodegradable ones. So once we close the wounds with the suture thread, we don't have to remove the thread later. Okay, so those are the suture materials that are biodegradable ones. Then there are screw, anchor, which we put to fix a muscle or tendon into the bones, that obviously you don't have to remove it because it is another biodegradable ones. So it reduces the chances of again removing it. So the most commonly used one among these is the polylactic acid. There are other ones, the polyglycolic, the polydiaxone, and the polycaprolactone. The most commonly one is the polylactone because the degradation product which is produced in this is the lactic acid, which is normally present in the body in the Krebs cycle. These are the pictures of some of the biodegradable implants that we use. All the left in A, although the top row is all the screws, the biodegradable screws, because once you put into the body, you don't have to remove it. Lower ones are the plates, same way once you put, you don't have to remove it. Yeah, elevate, that is, you don't have to remove it. So to remove an implant, we'll have to usually go take the patient again into the OT, operation theater, that can be reduced. And support matrix for drug delivery. Sometimes with this biodegradable products, we mix an antibiotic so that the antibiotic can locally act on the body. Instead of giving as tablets or injections, we mix it with this and give it directly locally into the wound site. So that will prevent the infection, and also you don't have to remove the implant. But some disadvantages will be there with everything. What are the disadvantages? This high concentration of lactic acid that is released in the surrounding regions may sometimes cause biocompatibility problems. Mechanical properties, the strength of that often decreases at a very faster rate. So if the bone fails to fuse at a faster rate at the given period of time, these materials have no strength left. So even the manufacturing is considered as to be very tough because the fabrication degradation materials are produced may change the final implant. Next, coming to the silicones that we use. Silicones are weaker, not that strong. They, poor strength and wear capability. So these are not used for lower limbs, but can be often used for the non-weight bearing, like the hand, as it's shown in the picture. The one of the joints of the fingers, that is the metacarpophalangeal joint. It is a joint at the finger and the palm where each other. There, they have used an implant. Next, coming to the carbon fibers that we use. These are the carbon fiber implants that we use. The first image, that is of a implant that we put in the leg. Next is the plate. Next implant we usually use for the upper limb, that is the humerus, the arm bone, and then the radius, that is the forearm bones. So this comes with a range of orthopedic application that can be used for total hip replacement. Plates are made up of carbon fibers, nails, washers, and external fixators. So advantages, they are radiolucent on X-ray. That means it cannot be seen in an X-ray. Extremely lightweight, but much stronger than the steel, which we normally have been using till now. Till now, there have been no cases where an implant has broken if it's made up of a carbon fiber. Bio-inert material, as I said, what is bio-inert? But nothing but there will be no reactions from the body to the materials. So no immune reactions to the materials. They are less rigid to allow micro movement. Anything, if it has to use, some micro movements has to be there. If it is a complete 100% rigid structure, the failure chances are more. So all this micro movement, the carbon fiber plates still allow slight bending of the plate. Everything that we can use so that it perfectly fits on the bone can be done. What are the disadvantages? It's made up of carbon, so that carbon debris can be released in the surrounding medium. Yeah, the main limitation is the cost. So not everybody can afford. Normally, the patients that can afford will be the stainless steel ones. The carbon fiber plates are usually more expensive, so not everybody can afford it. Tissue adhesives, but these are nothing but not the fibrin gels that we use to close a wound. So coming to the newer advances that have been using right now, may not be in all the places of India, but this have been started using in some places. So the aim of this is to use the materials that match the mechanical property of the bone. Yeah, so this you can see the left A1. Just want to know what these things are so that I can, the future slides I can explain better. This is the acetabular cup. Acetabular cup is nothing but a cup shaped structure that goes into your hip joint. whenever you want to have a hip replacement surgery, these three things are the ones that we put: the acetabular cup, the femoral head, and the femoral stem. The femoral stem and the femoral head fix with each other and fit into your thigh bone. The acetabular cup fits into the hip joint, and that together helps in the motion of the hip joint. Then the last image, the C, is the acetabular cup with a polyethylene liner. This is the newer one that have been started using nowadays. With the femoral head and femoral stem is the same thing. So what are the recent advances? What we try to do is not change the whole thing, but modify the currently available materials. The materials that are currently available right now, yeah, we try to minimize the harmful effects of those materials by modifying them. What we started doing now is using antibacterial implants. So these implants, their main function first thing is to stabilize the joint, stabilize the fracture. With stabilization of fracture, also they'll have some antibacterial properties. This is how the anti-cytokines are used. First, and this is the photo of the same hip joint, where you can see a stem and the head and the acetabular with cup which fixes into the hip joint. So this has been bactericidal coating will be done onto this implant so that you can act directly, an antibiotic effect is directly acted on the local side with the IV and the oral antibiotics that we give. Tantalum, this is on one of the newer latest materials that hit the orthopedic market. The benefit is it forms into a porous forms. So the tantalum bones have many micro holes. So what happens? The bone grows into these micro holes and will cause much more stability for the bone to heal. So the bony ingrowth that happens into these micro holes on the tantalum will cause more stability, will give a much more stability for the fracture to heal. Yeah, the mechanical properties of this novel metal depends upon its porosity and structure, and it is sufficient to provide mechanical support to the body during any part of the bony integration. Again, it's also virtually inert, that is no tissue response or a minimal tissue response, that is minimal immune response from the body. The combination of properties has led to the development of tantalum structures for backing of acetabular cups and spinal fusion cages. These features of the tantalum which we have seen, they want to develop the more and more acetabular cups. Now what normally acetabular cups that we use is metal or the polyethylene ones. The metal ones that they normally use, but they want to use tantalum in the future. This is the porous tantalum that are being clinically used, not here, but in future we would possibly want to use this even here, even in our medical practices. These are the acetabular cups. As I said, the top ones are the acetabular cups made up of tantalum, and the bottom ones are the screws which we can use. Next is the titanium. Titanium ones are being repeatedly used now for those patients which can afford. These are much more stronger than the stainless steel ones, but obviously much more expensive compared to the stainless steel metals that we use. But these are being regularly and increasingly being used nowadays because they are much more biocompatible, much more stronger mechanically, and they easily fit into the fracture, easily fit into the bone. And also any implant that we put, there's an investigation called as magnetic resonance imaging, an MRI imaging. So anything, if you want to get an MRI done on any part of the body, there should be no metals with you at that time. So the outer things that you wear, you can obviously remove it, but what if a metal is inside? What if a metal plate is inside the body? Stainless steel plate is inside the body. You can't get an MRI done. This is prevented if you use titanium. When you use titanium, there is no cross reaction with MRIs, so MRIs can be done. So titaniums are increasingly being used even in our day-to-day practices. Next, coming to the ceramic materials. Ceramic materials, these are solid inorganic compounds consisting of both metallic and non-metallic elements held together by ionic or covalent bonding. Some of the ceramic materials that we use are silica, zirconia, alumina, calcium, phosphate, and the biogas. This picture that you can see here, it is of a femoral head and acetabular cup. So materials like hydroxyapatite and zirconia are being explored for their bone-like structure, particularly in bone regeneration application with advancements in porosity and surface chemistry. So these ones are porous. As I said, porous is micro holes in that, which will help bone to grow into it and provide better stability. Some of the inert and inert ones are silica, alumina. Bioactive ones are the hydroxyapatite. So these are increasingly and almost every day used for the joint replacement, mainly the hip joint, the total joint replacement components, the acetabular component, the cup, and the femoral component are being increasingly used in these structures, the alumina and the zirconia. Bone graft substrates are also being used. So what are the advantages of these things? They are more biocompatible, less wear and tear, osteoconductive. What is osteoconductive? The implant itself will stimulate bone formation. Okay, excellent wettability, that is anything that is too dry can have more chance of breaking. So this has excellent wettability, higher compressive strength. So the more the compression is, the more stability it is. So the higher compressive strength, highly inert, that is no immune reactions from the body, good electrical and thermal insulators, and good aesthetic appearance. What are the disadvantages? They are typically brittle, low fracture toughness. So although these are more preferred, if there's another major trauma or a major accident, they can break again. Very difficult to process. That is the reason they are more expensive. Low tensile strength. So easily it can crack. As I said, very expensive. Next is the aluminum. This is a white crystalline aluminum oxide that is used. It's again another ceramic material known for its strength, hardness, and thermal resistance. This alumina again is used for the same thing, for a joint replacement. That is used for femoral heads and the other plates. Yeah, the femoral heads, bone screws and plates. And even if you cannot completely use the alumina, it is used as a porous coating on the femoral stems and spaces. That I said, the spaces, that is what it is kept between your knee and your tibia. For that also, this can be used. Next is the zirconia. This is the first image that you can see, that is the knee implant, the one which is used in the knee joint. The next to it is the one which is used in the hip joint. So femoral head, artificial knee, bone screws and plates. These are favored because of this will have less wear and tear, but obviously these are more expensive compared to the ultra high molecular weight polyethylene that we use in our day-to-day use. So right now what we are using is the metal on polyethylene, which are very being commonly used. The alternative, that is the bearing surfaces. So the metal on polyethylene are the ones which we normally use. The other things that we want to use is the ceramic on polyethylene. The picture that you can see is the ceramic on polyethylene means the acetabular cup is the ceramic one that is resting on a polyethylene spacer. As I told you, there's a picture here. Yeah, as I told you, the polyethylene, the C image, the polyethylene with the acetabular cup. The polyethylene is the liner that is placed between the acetabular cup and the femoral head. So ceramic on polyethylene is the newer one. The new generation that we used is ceramic on ceramic. So no metal is used here. The ceramic on ceramic, even the new generation is the metal on metal. The first one that you can see, that is the A, is the metal on metal. The C that you can see is the metal on polyethylene. You say, how do you say what implant that we used is based on what cup is used on what polyethylene liner that is used. There's another image where you can see a metal on polyethylene, the first one. The acetabular cup is metal with the polyethylene insert on a metal femoral head and metal femoral stem. The femoral stem and head are usually metal, but the next one is the newer one that is used, where they have used a ceramic femoral head. So acetabular cup, that is, and the ceramic insert on a ceramic femoral head. So this is a ceramic on ceramic. See, this is again a metal on polyethylene. You can see a metal acetabular cup with a polyethylene liner. Next to it is a metal on metal, where both the acetabular cup and the liner is metal. Next one is ceramic on ceramic, where the acetabular cup is ceramic And also the femoral head is ceramic. Next, which we want to use are the bioactive ceramics. These are the bone graft substitutes coating on the metallic implants. So the one which is used is the hydroxyapatite, where calcium sulfate is used. These are the ones where calcium sulfate coating is done on them. So calcium phosphate. So calcium phosphate is a bioactive degradable ceramic. So you can see in this picture that it's a normal implant that is used, but calcium phosphate coating has been done. So electrode deposited calcium phosphate coating has been done. So they cannot be used in high load bearing devices due to its strength and toughness. Uses, it is used to repair materials for bones like trauma or anything. Void filling, like I said, when a bone tumor is removed, the void that is created, void or space that is created in the bone, once you remove the bone tumor, that can be filled with this calcium phosphate. Repair and fusion of vertebra. Vertebra is the spine bones that can be also fixed with this, and direct drug delivery. You mix any medicinal antibiotic that you want and directly supply. Next is the bioactive scaffolds. This is the bone, when there's a bony fracture. So to help it grow better, we can directly give growth factors or stem cells into the scaffolds. So scaffolds are, these materials are just made not for stabilization, but just to directly infuse the growth factors. So normally a bone may take 6 weeks to heal, 6 weeks to above 6 weeks normally it takes to heal. So with these growth factors, we want to stimulate the bone regeneration at a faster rate. Next is the magnesium alloys. So they are very good biodegradability. So again, you don't have to remove it. Implant removal thing will be reduced. But again, the corrosion of this magnesium is at a higher pace. So currently the studies are going on as to how to use this for our day-to-day activities. Next is the 3D printing. This is the newer one which has come, which people have started using. Outside India, it's already started, not here. So this enables the creation of customized implants with complex geometries. So there are some parts of the body where the geometries are different in different people. So what do? They take a complete CT scan of the patient and they make a 3D bone material outside the body. So before you go into the body, before you open up and see what the fracture is, a complete 3D material is outside the body is already seen. So once you see this, you can easily keep the plates and see which plate fits the best. Complete fixation of that cement structure can be done, and then you open and you obviously get the same thing and it'll be easier to fix. So 3D printing, see, this is the 3D printing where especially it is used in the hip joint, because hip joint is a very tough joint to operate. So they'll completely open up, get a 3D structure made. The black one that you can see, the 3D structure that is made, with the blue one that is the implant that has been kept and seen. And once it is seen, the complete structure, then you can fix it on, you can open up the joint and fix it. Next is the hip joint, where plates have been placed to fix the hip joint. These are some of the titanium implants that are made using the 3D reconstruction. Yeah. The surface modifications, these are to utilize the coatings on titanium implants to enhance the bone cell attachments and improve osteointegration. The surface modifications that are being done on a day-to-day basis, so that it better heals and better fixes into the bones. So with time, the size of the screw, so the screw is made up of threads. The round thing that you can see in a screw are called as threads. So these threads, increasing the space of these threads, decreasing the space of these threads. So every day newer things are done so that they enhance the bone cell attachment, so that the screw back out. Screw back out nothing means once you put the screw into the body to fix the fracture, you finish everything, you come out, the screw comes out by itself. So to prevent the screw back out or other things, surface modifications are being done. Next is the biomimetic materials. So developing materials with chemical composition similar to the bone. So as I said, most of the things, if they have a minimal immune response, the body will not accept it. So what they're trying to do is now produce the materials which are very similar to the bone. So how is it done? How is the osteointegration? That is, make it very similar to the bone. How is it done? It is coated with the hydroxyapatite nanoceramics, coated with some growth factor that are normally present in a bone. So in the implant also you put the growth factors. So the body thinks it's a part of the body, and coated with the extracellular matrix. Extracellular matrix is nothing but the outer part of a bone. So this extracellular matrix is placed on the bone, and then this implant is used in the body. The body will think it as a part of itself, so it will not produce any immune reactions. And also to reduce the implant inflammation. So anytime you put an implant, inflammation can happen because of the infections. So the drug coated. So first of all, before you put it, before the infection comes, you load it with antibiotics and put it. So it itself will not cause any infection to come. And that also helps in the detaching of the bacteria. The drug coated, which helps in killing of the bacteria. The last one, this is the nanotechnology that have been used increasingly nowadays, where they're incorporating the nanoparticles into scaffolds to enhance the bioactivity and promote healing. So whenever there is a tumor cell that is in the body, so what we do is what we use is try to resect as much as tumor cells from the body. Whereas with nanotechnology, nanoparticles are directly put into the wound site, and there the locally treatment occurs where the nanoparticles will attach itself to the tumor cells and eliminate them. So targeting the tumor cells directly by the nanoparticles can help in eliminating them. So in the end, yeah, so first of all, adequate knowledge of the implant is an essential. Which implant for which patient has to be known before taking up to the operation theater. Which implant has to be used? Is there any advanced implant that we can use? Can the patient afford? Everything has to be seen before making the best choice. So anything that we use, that has to be very satisfying results both for us and the patient. So anything that is good for the patient but the patient is not satisfied, that's also every time we have to discuss them so that the best implant that we have can be used. So any advancement in this mechanical engineer can obviously help a lot to the orthopedic surgeons. Anything that we use right now, if it's not helping us enough, any advancements that I've discussed now, which is not yet come in our day-to-day practice, can obviously help us. So from the first passive role in which replacement by substitution was the target. So before, just we had to remove it and keep a new one. Today at all levels, the proactive biomaterials are typically required for assisting the healthy cells. So before, the only thing was whichever bone is dead, remove it, place a new implant. Whereas now they don't want to remove any part of the body, rather than helping in assisting the healthy cells to regenerate. The trend today is from a more passive towards a more active role for the biomaterials. So as a clinician, one should always disregard any notion that any modern technology they have the ability to replace. No, it's not possible to replace any living organism, no matter how modern technology reaches. It's always very tough to replace an original structure. But we try as more as possible with an artificial organ that we're using to as much as get accepted by the body, but it's not completely possible to replace any living organisms. And these are just the references that I've used. Thank you, all of you, for listening to me.
Thank you, sir. Participants are welcome to ask questions or clear any doubts. Please unmute yourself and share your queries.
Dr. Suresh sir, good afternoon, sir.
Hello, yeah, good afternoon.
Sir, this is Lokesh from Aeronautical Department. Sir, very interesting topic, sir. Thanks
Yeah,
for sharing your insights regarding
no problem. Thank you
biomaterials.
so much.
Yes, sir. So I have a small query.
Yeah.
You have shared in a bone implanting technique.
Yeah.
like just after the femoral head, there are three combinations you have discussed. That is metal with metal combination, and
Yeah.
metal with ceramic,
Yeah.
and polythene and metal combination.
Yeah.
So, can you please enlighten me with what makes the three big differences to choose the material combinations here, sir?
Yeah. 1 second. I'll just get back to the one.
Yes.
This is the one, right?
Yes, sir. Yeah, yes.
Yeah.
100%.
So the metal on polyethylene is the one which is commonly used now.
Okay.
So when we use a metal on polyethylene, this is the cheaper ones compared to the newer ones. This have to compare the metal on polyethylene compared to the ceramic on ceramic. Ceramic on ceramic will have less wear and tear compared to the metal on polyethylene. When the metal is there on a polyethylene, that will have more wear and tear. Wear and tear means with time it will start degrading. Same thing with metal on metal. Metal on metal will have a more friction that is occurring on them. So the one which we use normally are the metal on polyethylene. Why we can't use the other ones is they're more expensive. So with time, the implants are not even available to us right now. The ceramic on ceramic, which is the best implant right now, which has the least wear and tear, better looking, more accepted by the body. So the chances of the implant failure are less, are all better in the ceramic on ceramic because the ceramic is better accepted than the metal. Ceramic has micro pores on them. So this ceramic micropore, the ceramic material is made up in such a way that the micropores that are present on them are more better accepted by the body. So ceramic and ceramic although it's the best one, why we can't use it nowadays? Because of just one thing, it is more expensive. And also which implant that we use is also to be seen on what the patient wants. So patient is a very active athlete. Ceramic and ceramic, although it's the best one, may not be used on them because although it's the best implant, the tension that it can bear is comparatively lesser. So on a very active patient, if it's a very old aged patient, okay, we can use. But if it's a very active patient, we would want to use a metal on metal ones. Metal on metal ones we'll have to use so that it's a more rigid structure. But the chances of failure are also high. So basically, every implant that we have to use is different for different patients. You can never say that this material can be used for this patient. Okay.
Yes, sir. Yes, sir. Thank you. Thank you. Thank you so much. Sir, then one more thing that we have discussed many different categories of biomaterials, but it is very clearly representing that there are few advantages also comes up with many drawbacks. For example, when you're talking about bone cement, and also there are tantalum and very expensive and titanium also. So all these are come up with the first top priority is the cost. Majorly they're expensive. What is your
Yeah.
call on for choosing these materials?
No, see, for example, cement. Cement, although it is expensive, we have to use it. Okay, the implant that I told you, the femoral stem that we see here, you can
Okay.
see this femoral stems here, right?
Yes.
This
Yes.
femoral stem that you can see where the femur is written just above the femoral stem. That femoral stem has to completely perfectly fit into the body. So for it to completely fit, cement will have to use. So although the cement has more disadvantages that it causes a thermal reaction, it causes reducing the blood pressure. These are the calls that you have to take where even though it is expensive, even though it has disadvantages, we have to compare with the advantages that it has. Everything that we use will have advantages and disadvantages based on what patient requirements are there. So for example, if a patient you're operating on a very early basis, for example, a young patient you're operating on a hip replacement surgery, there are chances that after 15 years, there will be a failure of the hip implants. So you will have to do a repeat surgery. Every implant will fail after 10 to 15 years. You have to do a repeat surgery on that patient. On such patient, do you want to put cement, which will be tougher to remove, which will be tougher to do a repeat surgery? On such patients, you don't use. Same thing with tantalum. It is a newer structure, it is more expensive and better, but not affordable by everyone. I'm not saying that stainless steel is bad. The one which we use on a day-to-day basis are obviously very good. But with time, some patients who can afford will want a better implant. For example, there are chances that the stainless steel will survive for 10 to 15 years. Titanium will survive for 15 to 20 years. The difference is not much, but if you have given an option, you want to choose the best one for a higher cost or a bit lower one for a cheaper cost. That depends upon every patient. Doctor can only tell that this is better or that is better, but it's always the choice of the patient. So we as doctors, when we give all the options to them. So this is a better structure, this is a better implant, but it's a more expensive one. This is a slightly lesser, cheaper implant, but it's not that good as that one. So that depends upon the patient. So normally patients that we get in India usually are through the schemes and insurance ones. So it depends. We normally use the stainless steel ones, which I've been using till now. So just because I said the other implant is better doesn't mean the stainless steel is bad. It is still the one of the most commonly used implant nowadays.
Yes, sir. Yes, sir. Thank you. Thank you. I agree with your view, sir. But there's some problem with though if the cost is not an issue. If, for example, one category of alloys, you said magnesium alloy. Though we have not a solution of finding the corrosion problem, so there's still research is going on as per suggestion. So, like if that is the case, when it's a need of that material, it is very difficult to cope up with the biocompatibility. Is it right,
Yeah,
sir?
yeah, yeah.
Yes, sir. So thank you so much, sir. Thank you so much.
Yeah. Thank you all of you.
This is Professor Nitin Joshua from Marine Engineering Department, sir.
Hello, yeah, I can't hear you properly.
Sir, this is Professor Nitin, sir.
Okay.
Sir, what are the different challenges for the production of these biomedical materials, sir?
No, you can hear me?
What are the different biggest challenges for the scaling up of the production of these biomedical materials, sir?
Yeah, the main thing that we have problem is obviously the cost and what is the need of it. So when something that has already been going on in India, the already the stainless steel is being used. So the higher biomaterials, if the need of it and how much requirement is there by the patient is lesser right now in the current situation in India compared to outside. So that is one of the main challenge where the cost of production is high. So if the cost of production is high, obviously the one who is producing it will see how much he is able to get back his thing. So if the usage is less, obviously the production also decreases. So in a way, we are always one step behind the some developed countries because there the cost of production is also, even though it is high, it is being used at a much higher pace compared to here. So the main problem that we have is not not that we have good places. We have all the technologies that is required to produce better implants, but obviously the requirement of that is comparatively lesser. For example, as I told you, titanium implants are continuously used in the US or UK. Here, out of every 5 patients, 1 patient will use titanium. The stainless steel is still the most used ones. Hello? Yeah?
Yes, sir, yes,
Any
sir.
other
Thank you so much,
queries?
sir. Sir, according to your view,
Yeah.
which will be the most promising biomaterials, sir, in future for the future biomedical applications?
In India, the titanium is the ones which is going to get developed in a
India, sir.
very faster pace.
In India, sir.
Right?
In India.
Yeah, in India, titanium is going to be an implant that is going to be get used in almost every surgery. Compared to 50 years back, when titanium was not used at all, titanium is now used in every 5 surgeries. I can say approximately 1 patient titanium is being used. Titanium is going to get increasingly used in almost all surgeries now because most of them have insurance. So titanium, they don't mind what the implant cost is. So titanium, some years back was twice of the stainless steel, but right now it has come down to 1.5 times, 1.6 times. So titanium is going to get to use the most. And the main thing of titanium is it is much stronger, lesser chance of it breaking, And obviously, you don't have to remove it if you want to get an MRI scan done. So I feel titanium is going to get used much in India as such.
Thank you, sir. Thank you.
Yeah, thank you.
Thank you for that wonderful session, sir. On behalf of the organizing team, I extend our heartfelt gratitude for delivering an insightful and engaging session on recent advancement in materials for biomedical applications during a faculty development program on advanced materials and manufacturing for engineering applications. Your expertise and thoughtful presentation provided valuable knowledge and perspectives that will greatly benefit the participants. We truly appreciate the time and effort you took to contribute to the success of this program. Thank you once again for your valuable contribution, sir.
Yeah, yeah. Thank you. And also like to thank all of you, for giving me an opportunity to share my views with you guys. Okay,
Thank you, sir.
thank you.
Thank you.
Thank you,
So
sir.
Thank you. So that brings us to the end of today's session of the faculty development program. Thank you all for your participation. See you tomorrow.
Thank you, sir.
Thank you, Sunil sir, for hosting session. Sir, now Prakash sir, Madhusudan sir, I informed Madhusudan sir already. To end the
Yes,
session.
sir. Can I stop it now?
Yes,
Yeah,
sir.
sir.
Yes.
Yes, sir.